Hani Badakhdah, the hidden man who was behind all of this event. We really would like to thank you, Dr. Hani, for all of this great job. Dr. Hani is a consultant pediatric surgeon at Dr. Idris Specialized Medical Center in Jeddah, diabetic and the endocrinology center, King Fahd Specialist Hospital in Buraida. You can start, Dr. Hani.
يعطيك العافية دكتور محمد. Impressive talk from Dr. Nasir and Dr. Kimawi. I hope my presentation will be on the same level. And after me, Dr. Hussam Darwish. I hope you guys enjoy my presentation. Okay, so my topic, unfortunately, I didn't, make any introduction about Charcot, so I went very advanced for Charcot reconstruction, surgical treatment for Charcot reconstruction. This is a great reference for if you're interested to read about the surgical reconstruction of diabetic foot and ankle. It's a great book. This is my picture with David Armstrong. Every time I catch him, I take a picture. Say he was very obese, 2013. This is in Netherlands, 2019. This is last week in Abu Dhabi. Surgical management of diabetic foot and ankle Charcot arthropathy. As you guys know, surgical management is very challengeable and very difficult in diabetic patient. Risk of major amputation of lower extremity is high in cases of Charcot arthropathy, especially if it's accompanied with osteomyelitis. Experienced specialized foot and ankle surgeon with subspecialty in management of diabetic foot and ankle problems is very essential to prevent and minimize the need for amputation. Decision regarding surgery is depend on the patient medical status, depend on the family and the surgeon expectation and MDT approach. Remember, diabetic foot, it's not a single man show, it's a multidisciplinary team approach. That's why we're making our conference to work as a team. The process of treating Charcot arthropathy is very extremely involved and long-term process with no guarantee. So after you're doing all this type of procedure, you might end up with amputation. Also in Charcot reconstruction, the patient need to understand that it's not only one surgery, it's multiple surgeries. And also it's a long term of immobilization. So we have to discuss with the patient and his family. And also usually when I discuss the surgery, I ask the patient, do you live which floor? Because it's really important for me, because if I do surgery and the patient lives in the 5th floor, I guarantee my surgery will fail. So I want to make sure my patient live in the 1st floor or they have elevator in their home, because this is very important to increase your successful outcome. When we formulating the patient for surgery for Charcot reconstruction, by the way, not all Charcot foot, they need surgery. Most of the Charcot can be treated conservative. Only a few of the cases need surgical treatment, especially the one in the ankle joint. Before I start my procedure, I have to discuss with the patient and the family about the blood sugar level. If the hemoglobin A1C is very high, I don't take the patient to the surgery, wait, send the patient for endocrinology or diabetologist to control the blood sugar. The optimal A1C below 8, and then I have to address the creatinine, or if there is any chronic kidney disease, because it will affect my surgical outcome. So the next few slides, I will discuss my cases, because there is no clear guidelines for surgical reconstructions. It's based on a surgeon experience. So I will go step by step on how we work these cases. So case number 1, this is a patient with multiple comorbidities, history of neglected right ankle neuropathic fracture, complicated with the Charcot arthropathy and osteomyelitis. This patient hemoglobin A1C, but because of the deformity is severe and it's open wound with osteomyelitis, so I consulted in this case endocrinologist, I consulted infectious disease, and then I consulted internal medicine to manage the comorbidity of the patients. This is the deformity. If you can see, the ankle is completely dislocated, and the patient, she has wound, and this is how the foot in varus position. This is the X-ray. As you notice, it's a fracture with osteomyelitis. We decided to take the patient to the surgery. I cannot wait until the hemoglobin A1C to reach the optimal level, because this is considered as an urgent case. So we took the patient to the surgery. We put her in a circular external fixation. The reason why we don't use internal fixation because there is osteomyelitis and open wound. So we decided to do it one stage and we closed the wound. And this is the patient 4 months. Usually I keep circular external fixation for a month. If you can see, there is a solid fusion at the ankle joint. This is the patient after removal of circular external fixation. As you can see, the alignment of the foot and ankle. And this is the patient with a complete wound healing. There is a video here. I want to open it. Mustafa, can you help please?
السلام عليكم ورحمة الله وبركاته. هذه مريضتنا الحمد لله بعد إزالة جهاز إليزورف من رجلها بعد 4 شهور.
الفوت is a ankle joint is very stable.
الكاحل بعد ما كان مقرر لها عملية بتر من تحت الركبة وتم المحافظة على القدم. الحمد لله على السلامة يا خالد.
Second case, DM. If you notice, most of the DM patient, they have multiple comorbidities. So that's why multidisciplinary team is very essential to increase your success rate. DM with multiple comorbidity, obesity, right ankle dislocation with non-healing infected wound. This is the patient with infection. We did multiple surgeries. We did incision and drainage. This is the X-ray. She has a Charcot arthropathy at subtalar joint level. This is the first stage. We did incision and drainage.
الأنكل تماما مخلوع من مكانه. هذا الجرح.
This is in the surgery. We use circular external fixation. Again, I cannot use any internal fixation because there is osteomyelitis and open wound. In these cases, we use antibiotic beads, absorbable, so I don't have to take the patient for another surgery to remove the beads. And also we consulted infectious disease to manage the antibiotics. This is the patient 4 months.
حرك رجولك يا خالد. يا سلام عليك. ممتاز روعة ما شاء الله تبارك الله.
Third case, DM, obesity. Also, there is something common between all the diabetic patients. They are obese with the right ankle Charcot arthropathy with valgus deformity. This case was done here in القصيم. This is one of the cases done in مركز الشيخ فهد العويضة because we started to do this procedures just recently in مركز الشيخ فهد العويضة. This is the second case was done, and this is the deformity.
بسم الله الرحمن الرحيم. صباح الخير. هذه رجل المريضة قبل العملية مخلوعة تماما من مفصل الكاحل وفي جرح في المنطقة.
This is the X-ray. If you notice, it's in a valgus position. You see how is the fibula is almost medially with the tibia. So again, we put circular external fixation. We reduced the deformity. We kept the patient for 4 months.
السلام عليكم ورحمة الله وبركاته. هذه حالة شاركوت، ثاني حالة في القصيم الحمد لله. بعد ترميم مفصل الكاحل الحمد لله المريضة بعد 4 شهور تم إزالة الجهاز والحمد لله المفصل ثابت. الله.
This is the X-ray 4 months. Again, this is not all the cases are complicated. There is a simple cases. You don't have to do all this type of crazy stuff. DM patient with a chronic kidney disease, obesity, non-healing wound on the right foot for almost 7 years. We did just simple procedure. Dr. Kimawi discussed about the Achilles tendon lengthening. So we did simple thing. We just did exostectomy and Achilles tendon lengthening, and we closed the wound. If you can see just by doing the biomechanic, look how was the calcaneus before tendo Achilles lengthening, and after we did Achilles tendon lengthening, you see a big difference in the deformity. So a simple procedure, and then this is the wound completely healed after 3 months. Another case, DM patient, obese, multiple comorbidities, history of non-healing wound, left ankle with ankle dislocation and instability. You see how bad is the deformity? The same thing, we put them in circular external fixator. And this is the patient 4 months after the surgery. This is the x-rays.
هذا المريض ما شاء الله تبارك الله بعد تصحيح شاركوت بالمفصل الكاحل الايسر ما شاء الله المفصل ثابت.
وهذا المريض بيمشي ما شاء الله تبارك الله. We have, after we finish our surgery, we have to protect the foot. We put them in a air cast or a body armor to protect the deformity. And after that, we put them in a custom-made shoes. Imagine this patient with the amputation. You think he will move? Unfortunately, no. So another case, young patient 23 with a chronic kidney disease, severe deformity. He was advised amputation. So we took him to the surgery, the osteomyelitis, we resect the talus, put him in circular external fixation. And this is the patient 4 months, great alignment, patient is walking with no amputation.
حرك رجولك يا زياد. ما شاء الله تبارك الله الحمد لله بعد عملية تثبيت وتصحيح. حرك رجولك.
Another case of Charcot, clean with no open wound.
حرك يا سلام.
We place circular external fixator, and this is the patient 4 months. This is the x-rays.
السلام عليكم ورحمة الله وبركاته. هذا مريض كان عنده قدم شاركوت الحمد لله تم تثبيته.
Another case, this is very aggressive case with the infection. DM, ischemic heart disease, ejection fraction 20%, history of multiple foot surgery with midfoot osteomyelitis and Charcot. You can see severe osteomyelitis on the first ray and also involve the navicular bone and the medial cuneiform. So we took the patient to the surgery. We used the circular external fixator. If you notice, there is a different construct for the circular external fixator depending on the infection and the deformity. And this is the x-rays. And this is the patient after the healing. And this is the x-rays 4 months after the surgery. You can see pseudoarthrosis at the midfoot area. And this is the patient.
ممتاز ممتاز جميل جدا.
I will show you some cases of failure. It's not my cases, but failure of cases because if you don't use the right fixation for the deformity, definitely it will fail because Charcot is completely different from other deformities. This patient with IM nail, if you can notice, there is a broken of the screws and the calcaneus bone is already fragmented. So I don't think there is any option to save this patient limb. And he was asking me for my opinion. I refused to put any IM nail for this patient because I know the risk of failure is very high. Another example of Charcot reconstruction with a failure. So you have to be very careful when you select your patient, when you choose your fixation to correct the deformity. As I mentioned, not all Charcot deformity requires surgery. Few of them, they need surgery. Most of them, they need conservative surgery, conservative treatment. Take home message, MDT approach is very essential. If you notice, most of my cases, they have multiple comorbidities. You cannot do it by yourself. Early recognition is very important, and identification of Charcot will increase the chance of limb salvage and reduce major amputation. Not all Charcot and Charcot foot and ankle deformity require surgical treatment. Experienced specialized foot and ankle surgeon with specialty in diabetic foot and ankle surgery is very important to reduce the chance of complication and increase the chance of success. And I think that's my presentation. Thank you so much. I finished on time, 14 and 26 minutes.